We spent some time on the bony thorax last week in discussion of chest. So today we'll include the sternum and the ribs. Now, what makes the difference? What's the difference between the chest section and the bony thorax section? There's not much difference at all. So when I start doing the lecture and review, you will see that there are a lot of similarities. The only difference between what you're doing for chest x-ray versus a bony thorax, in this case we're talking more specifically about the ribs, are the technical factors. When we do a chest x-ray, we want long scale, okay, a lot of grays, to distinguish all the different anatomical structures of this area, because we got bone, we got muscle, we got fat, we got air, versus the bony thorax, ribs, we want short scale because we're evaluating bone. But again, as we go through this, you will see that when we're doing the bony thorax, it's going to be at the same level, centered at the level of T7. The oblique views that we talked about last week, we also have oblique views for the ribs. RAO, any anterior obliques, you're looking at the side that's furthest away. LA, posterior oblique, you're looking at the side closest towards the image receptor. Okay, so we're going to fly through this.
A question. In the book says 12 thoracic vertebra. It's included in bony thorax also. On your slide, it was like 3, I believe, isn't it? Like scapula, clavicle.
The scapula, the clavicle is part of the shoulder girdle. So it's not part of the bony thorax. So when you're looking at this, you see the clavicle here, which is part of the rib cage anatomy. It's included as the shoulder girdle, not the bony thorax. So you're saying my previous...
I think it's what
You said it.
Yeah, I said it? I said the clavicle was part of it?
As far as like what you, it's like as far as what's considered a bony thorax, the clavicle and the scapula was included.
Okay, let me go back. Let me go back.
Put the tape on.
I have the video if you want to see it.
No, it's okay. Here's the chest, right?
It wasn't on the slide.
I think
You
there.
told us to add it.
It's way down.
I did?
Yeah, you said add the clavicle and the scapula.
If you told us to add it, you would have extra credit maybe?
No, because you weren't tested on it.
Bahar, you're like the poster child for extra credit.
Right there, you said it was blocked out, but we needed to add a clavicle and scapula.
Oh yeah, I remember
Yeah,
that.
move the yellow box and we'll see it.
And then 12 pair of
Got
thoracic
12 pair of
vertebra,
ribs, 12
which is
vertebrae.
missing over here, but it's in the book.
Oh.
Yeah, in the picture it's there. That's it. Part of, it's the third slide.
Thorax. And I said add the scapula?
Oh, yep, yes you did.
Now what about in the book? What does the book say about the bony thorax for this section of the chest?
I just didn't bring that. But then when they started saying all that, I go,
What does it say, Shannon?
it's just slow. It's got a lot of stuff in there. What's next? It doesn't like bringing it forward. Like sticking it to itself.
I don't know, I have that too, yeah. I think that we're not doing it.
Chest, respiratory.
Yeah, the book includes 2 clavicles and 2 scapulas.
Okay, and this is on,
Page 72.
I got it.
Chest, the radiographic
Can you
anatomy.
show me just show me the page, just hold it up. Okay. Okay, bony thorax, part of skeletal system, protective framework, da 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 da. Anteriorly, the bony thorax consists of the sternum, okay. Manubrium, superiorly, the bony thorax consists of 2 clavicles and 2 scapula. Okay. And 12 vertebrae.
That's good too.
Okay.
Oh, yeah.
Okay. Let's go back to
Well, like radiographically, we usually don't include them, right?
No, I mean it's. I mean now I'm contradicting myself. Okay, so here, so bony thorax and this. So we need to include. We said the clavicles.
Yeah.
And this
Should
guy.
I modify it? Okay, so include here the clavicles
And scapulas.
and the scapulae. Is it scapulas or scapulae?
Scapulae, plural.
Scapulae. So add on here, I can't do this because I have this file open up downstairs, so I can't do any modification, but add the 2 clavicles and the 2 scapulae. 2 clavicles, 2 scapulae. And then on the previous, and then what, did we omit something over here? So we got 12, and it should also include here on this slide 12 thoracic vertebrae.
I'm clock.
Yes.
Yeah, from what I said the last time.
Write that down.
So I will fix the slides. Okay, I gotta study this more because it doesn't make any sense because when we did the shoulder, we included the scapula and the clavicle and the proximal humerus. That's part of the shoulder girdle.
Yeah.
So it's not consistent with what the book is saying about what the bony thorax is. So I'll review that. Okay. Any other questions?
I think we're good.
Okay. So let's go back over here. Here.
Yep.
All right. Okay, so do I need to mention anything else on here?
No.
Okay, so the bony thorax protects the organs of respiratory, the heart, and also the great vessels. All right, specifically on the sternum. The sternum is broken down or broken up to 3 main sections. The most superior is going to be the manubrium. Between the manubrium and the second section here, which is the body, is the sternal angle. The sternal angle is going to be located around the level of T4, T5, and this is a palpable landmark because it also indicates where the trachea bifurcates into the right main bronchus. Okay, so T4, T5 is around the area where the trachea bifurcates into the right and left main bronchus. The third part of the sternum is the xiphoid process. Again, another palpable bony landmark that's located at the level of T9, T10. Again, a review on the topical landmarks. The jugular notch is at the level of T2, T3. It is the landmark that we palpate for to localize the level of T7, which is mid-thorax. So we palpate for that landmark. 3 to 4 inches below that will take us at the level of T7. And as we said earlier, T4, T5 is the area where the trachea terminates and bifurcates into the left and right bronchus. Xiphoid process is another palpable landmark that we'll talk about later in different types of views. L2, L3 is the lower margin of the ribs. L2, L3, lower margin of the ribs. The articulation between ribs and the sternum. At the very top, well, first I'll talk about the clavicle. So the clavicle, the first facet here, is what forms the, hold on just a moment here. Let me look at this real quick. Okay, so here the clavicle and the sternum. What joint does that form?
SC joint.
SC joint, the sternoclavicular joint. And then we have the first facet here for rib attachment is the first sternocostal or the sternocondral joint. I don't know if that's in your book. I added this later. So you may want to write that down. So the articulation between the ribs and the sternum is your sternocostal joint or your sternocondral joint. Either one of those are correct. But do we know the difference when we say sternocostal versus sternocondral? Because the true articulation between the ribs and the sternum is not actually bone to bone.
It's cartilage to bone,
It's
right?
cartilage. So the more appropriate would be the sternocondral
Chondral.
joint, but this is also appropriate, but this is more correct. It's the sternocondral because it's cartilage to the sternum. Now we have facets in the sternum that allows for the articulation of the ribs, and you only have 7 facets on the sternum, 7 facets. And because of that, it defines or classifies the different ribs and how they are classified in that 1 through 7, because again, you have the facets that allows articulation. If you have 7 notches, it articulates with the 7 ribs. This is why ribs 1 through 7 is called the true ribs. Whereas 8 to 12, they share a cartilage. Okay, they share a cartilage, and so those are called false ribs. And then ribs number 11 and 12, they have no cartilage at all, and they are called floating ribs. So 11 and 12 can be called false ribs, but more specifically, they're called floating ribs.
Can you go back?
Okay? Rib anatomy. The rib has a posterior end and it has an anterior end, beginning with the posterior end. Okay? It's also known as the vertebral end because it articulates with the thoracic vertebrae. The head of the rib is what forms the costrovertebral joint, and that's the articulation between the posterior rib and the thoracic body. The thoracic body. Off the head you have the neck. Then you have 2 bumpy protrusions. It could be a single or it can be a double protrusion. It has a rough edge to it, and that is the tubercle, which forms the costal-transverse joint. So it is the articulation between the tubercle of the rib and the transverse process of the thoracic vertebrae. Articulation between the tubercle of the rib and the transverse process of the thoracic vertebrae. From the neck, the rib starts to take a very drastic turn or angulation. This is known as the angle of the rib. And then the main portion of the rib, the longest portion of the rib, is the shaft or the body. And then at the end, the sternal end, where the bone meets the cartilage, is known as the costochondral joint. So this is bone and cartilage articulation. So the sternal end of the bone articulates with the cartilage, forming the costochondral joint. So the anatomy of the rib, as you notice here, is that it isn't in true, what do you call it, true profile, in that there is a difference between the head of the rib and the sternal end of the rib, in which the rib has a downward projection. So there's going to be a difference between the head and the sternal end, approximately 3 to 5 inches.
Thank you.
Within the ribs, you're going to find a bunch of grooves that allows for blood vessels and nerves. And these little grooves are called the costal grooves. And if you've ever had any type of rib injury, it hurts. Lots of nerves, highly vascular. Okay, so just kind of keep this in mind as we're talking about the bony thorax anatomy in reference to an x-ray. So just remember this type of orientation. So this is a picture here with ribs without the sternum and the costal cartilage. So they took the cartilage out of the middle here in the anterior part. The characteristic of the ribs, beginning with the most superior, they are going to be very short and broad and most vertical and sharply curved. Short and broad and most vertical and sharply curved. As it descends down towards the 7th rib, they get a little bit longer. They get a little bit longer. They're still vertical, but they're starting to take that horizontal formation, but it's still pointing downwards. Again, up here though, they're going to point a little bit more downward than they are down here. So they're more vertical up here at the shorter ribs. Now after the 7th rib, right around the 7th rib, so again from about 1 to 6, 7, they get longer. From 7 on down, they get shorter. So from the 7th rib down, they get shorter. The widest portion is going to be found, or the widest diameter is going to be found at the 8th rib. Okay. You guys got this? Before I move forward? So short and broad, most vertical and sharply curved in the upper ribs. They get longer towards the 7th. Get longer towards the 7th and get shorter from the 7th on. All right, articulations of the bony thorax. What is this joint called? A. This is between the bone and the cartilage. Costochondral joint. B.
The SE joint.
So B, everybody agree on that? It's the SC joint versus C. That's the articulation with the first rib and the sternum. So that's your sternal
Chondral joint.
Sternocondral joint. Okay, and then D is also your sternocondral joint, right? Okay, what is E?
Those are your.
Okay, cartilage, but what ribs are we talking
Those
about?
are the false ribs.
That's your false ribs. Okay. All right, the articulation, your costal transverse joint, that's the topical of the rib, articulating with the transverse process of the thoracic vertebrae. Actually, both of them are that way. So the costotransverse and the costovertebral joints are both plane or gliding type of joints, and they are diarthrodial. They are synovial joints. Okay. Sternum. So what we have here in this particular view and projection here, this is what's known as an RAO sternum. We do this because we don't have a true AT of the sternum. Because superimposed on the sternum is what? It's your vertebral column, right? Yes, your spine. So we need to rotate the patient slightly between 15 to 20 degrees to remove the superimposition, which places now the sternum over the heart shadow. We do a breathing technique to blur out the surrounding anatomy to better visualize the sternum. So this is what it looks like. So you're actually seeing the sternum over the heart shadow, also being superimposed by some of the ribs. Anyways, let's look at A. What's A?
Jugular notch.
Jugular notch. You guys also call it what's the other name for that? Sternal notch, okay. Okay, jugular sternal notch. What's B?
SC joint
SC joint. Okay, C.
is the first sternal-chondral joint.
Okay, C is the first sternocondral joint. D,
Manubrium,
manubrium. E,
sternal angle,
sternal angle. What's F?
body,
The body. What's another name for the body?
shaft.
No. Shaft applies to long bones, by the way. Gladiolus. You guys remember that? Am I making this up?
It's on the slide, but.
Uh-huh. So the other name for the body of the sternum is the gladiolus. Did somebody say it's a flower? It's a flower? Yeah, I'm gonna leave that one alone.
Whatever works.
Okay, whatever works, right. And then G.
Xiphoid process.
Xiphoid process, okay, xiphoid process. All right, so this is what I was talking about earlier when we're trying to take an x-ray of the sternum. We'll spend some more time on this later on. But because here's the back, posterior, here's the anterior, generally the way we do a sternum, you got two basic views. One is an REO, the other one is a lateral. So with an REO, you're going to place the sternum as close to the image receptor as possible. Okay, and you know why we do that, right? Okay, to reduce any OID, okay? With larger, more barrel-chested patients, there's only going to be minimal amount of rotation, approximately 15 degrees, whereas someone who's a little bit thinner is going to require more of a rotation, approximately 20 degrees. And again, that throws the sternum out of superimposition over the vertebral column, okay? We'll spend some more time on this in just a little bit. Some technical factors to consider for the sternum. This is one of the projections where we utilize breathing. Okay, so breathing technique between 2 to 3 seconds. When I was a technologist, I like to shoot my sternums about 5 seconds. Okay, so I get better motion in the surrounding anatomy and keeps the sternum in focus. So I mean, 5 seconds, 4 to 5 seconds sounds like it's a lot, right? But if I increase my time, what am I going to do with my MA?
Decrease it.
Okay, so what is that law called?
Reciprocity.
The reciprocity law. Remember that? Reciprocity law. So as long as the total amount of exposure remains the same, you can manipulate your MA in your time. All right. So low KV. We're not using high KV. The bony thorax, when we're looking at the ribs, when we're looking at the sternum, we're looking at bone. So we use low KVs. Low KVs gives us what kind of contrast?
High contrast.
High contrast. Again, we're focusing on bone, so we want short contrast. Short scale, high contrast. Short scale, high contrast. Okay? SID is approximately 40 inches. Okay, so it's a normal distance. The sternum is already up against the board, so there's no need for us to increase our SID. 40 is appropriate. And it looks something like that with the breathing technique. So when you look, and when you see this, you can see that the sternum is sharply in focus, whereas the rib and some of the lung markings are blurry, indicating motion. Okay, so we do want a breathing technique. Physician considerations for ribs. When we do ribs, you have a front and you have a back, right? You have posterior ribs, you have anterior ribs. Now, part of your dialogue, Miss Jones, where do you hurt? Where do you hurt? I hurt on the back side. So if they're hurting in the back, what is your projection? Are you going to do AP or PA?
AP.
AP. So it places the posterior ribs closest to the image receptor. If they have anterior rib pain, what is your projection now?
PA.
It's going to be PA because now we're placing the anterior ribs closest to the image receptor. Okay, we want the part of interest closest to the image receptor. All right. Now we also have two different sections that we need to focus on as well. So it's not only is it on the back or on the front, we also need to identify, is it upper ribs or is it lower ribs? Okay, because that will also define your technical factors that you're going to use. When you're doing upper ribs, you're shooting through a lung. Okay, we're shooting through lung. So your technical factors for upper ribs is going to be slightly lower because we're shooting through air. Breathing is also going to play a part in this because when we're looking at upper ribs, we're having our patient take a deep breath in to drop the diaphragm down so that we can see more of the upper ribs. You guys with me so far? Now your lower ribs will be, although it's divided, although your bony thorax is divided by the diaphragm, your lower ribs will still be around your abdominal area. Because it's around your abdominal area, we're using higher KVs. Because now we're going through abdominal mass. And if I want to visualize my lower ribs, if I want to get more of my lower ribs in my view, is it going to be done in inspiration or is it going to be done on expiration? Expiration is going to bring my diaphragm up. So now I get better shot of my lower ribs. Is that making sense? All right. So let's go ahead and we'll talk about axillary ribs here in just a moment. All right. So ribs above diaphragm, we do it in the upright. We choose to do it upright because just like in a chest x-ray, when you're upright, it drops the diaphragm down. You can get better inspiration visualizing 8 to 9 ribs. And you want to get 10 if possible. KV is going to be low. We're looking at bone. Remember your chest x-ray, what was your KV for chest?
High.
High, right? The higher the KV, the lower the contrast, we get a longer scale.